Good evening, friends. Thank you for joining us. So, my job today in the next few minutes is to take you through two abstracts, both of which pertains to immunotherapy in breast cancer. The first one is the JEPAR Nuvo study. JEPAR Nuvo study. This is a randomized phase two trial of the use of immunotherapy durvalumab in early triple negative breast cancer. Now, the background of this study is that by the time the study was designed, we already knew that the checkpoint inhibitor therapy, along with chemotherapy, is active in triple negative breast cancers. And when there were other drugs like atezolizumab and pembrolizumab, which had already moved into phase two and phase three trials, and they consistently showed that there's an improvement in pathological complete response when checkpoint inhibitor was added to chemotherapy. The IM Passion 031 study showed that when immunotherapy was added, the PAT-CR went up to 57%, and the Keynote 522 showed us that when immunotherapy was added to a four-drug regimen, which included platinum, the PAT-CR rate went up to 65%. So based on this trial was designed, JEPAR Nuvo, which was a randomized phase two trial. If you see in the trial design, just after randomization for the first 2 weeks, there was a window of opportunity. There was a run-in period where only durvalumab was given, and subsequently a repeat biopsy was performed, and then patients started on the standard chemotherapy, which was weekly paclitaxel for 12 weeks, followed by dose-dense EC into 4. And the randomization was to durvalumab 1,500 milligrams versus placebo. The pathological complete response at surgery was the primary endpoint of the study. The invasive disease-free survival, distant disease-free survival, and overall survival were important secondary endpoints. Initially, when the trial was designed, they had designed the trials so that the analysis would be done at 43 events. However, subsequently, the statistical plan was changed to perform the analysis at a median of 3.5 years of follow-up. Now, this is early breast cancer trial, so you see the disease and the patient characteristics were as expected. All of them were triple negative breast cancer, so almost 84% of them were grade 3. Node positive patients, about 30%. T3, T4 were only about 8%, 8 or 3.5%. So triple negative early breast cancers, and the randomization, if you see the consort figure, about 88 patients went into the durvalumab arm, of which all of them had surgery. Of the 86 patients who went into the placebo arm, one of them refused surgery. And at follow-up, there were 12 events in the durvalumab arm and 22 events, including 15 deaths in the placebo arm. Now, this trial was published earlier in 2019 with the PAT-CR data was available, and we see as expected when durvalumab was added, the PAT-CR went up from 44% to 53.4%. And if you see the forest plot, the benefit of PAT-CR was seen in almost every patient, every subgroup of patients. However, when some of the patients, when they had this window, that is one dose of durvalumab was given before, they seems to derive more benefit in terms of PAT-CR. But then when this study was presented last as ASCO meeting, the authors presented the event data, and then when you see the distant relapses, there was almost 13 relapses as compared to 6 relapses in the placebo group. So there was a big difference over there. And if you look at the invasive loco-regional relapses, there was 5 versus 4. Now, if you look at the Kaplan-Meier curves, if you see all invasive disease-free survival events, the 3-year absolute was about 85.6% versus 77.2%. And that is because 2 of these patients actually had contralateral invasive cancers. And if you remove them, and if you just look at distance disease-free survival, the 3-year was at impressive 91.7% in patients who received durvalumab versus 78.4%. And this was statistically significant. And if you look at overall survival at 3 years, that was 95.2% versus 83.5%. So these results are pretty similar. The Kaplan-Meier curves look very similar to the Keynote 522 data. And the thing about this trial was that durvalumab immunotherapy was actually given only in neoadjuvant period. there was no maintenance durvalumab given after surgery. And in spite of that, the authors were able to show, the study found that the difference in overall survival, distant disease-free survival and invasive disease-free survival was significant. Now, if you look at the forest plot here with the kind of patients who derive more benefit as compared to others, but there is no differential responses seen. All the delta was actually towards favoring durvalumab, and the benefit was more pronounced if the tumor was PD-L1 positive. Also, the outcomes in terms of overall survival and distant disease survival was excellent if the patient the patient achieved a PAT-CR rates. And if you look at the absolute numbers here, the invasive disease survival in patients who had a PAT-CR was almost 95.5%. And there were, as I told you, there are two events where the contralateral invasive cancers which were treated. And if you look at the overall survival in patients who had PAT-CR was 100%, distant disease-free survival of 100% in patients who received chemotherapy with durvalumab. And to compare that to patients who did not have a pathological complete response, in the placebo, the invasive disease-free survival was 70% as opposed to 76% in patients who had received durvalumab. So, in conclusion, these are the author's conclusion that there seems to be a survival advantage of using a shortened duration of immunotherapy along with standard chemotherapy. And therefore, this definitely requires testing in larger phase 3 trial. And this is consistent with what we have seen with Keynote 522 data. So my take on this is that this at least tells us that that immunotherapy can improve outcomes in early triple negative breast cancer. Second thing is it also is an exciting area of research that how much of immunotherapy is actually required, and if you are able to achieve a PAT-CR in just a shortened duration of chemoimmunotherapy, then maybe that maintenance immunotherapy can be omitted, and we look forward to other research to confirm the same data. Now, the second abstract I have to discuss is we're switching gears now to advanced disease. This is in metastatic lobular breast cancer, where it was a small study, single-arm study, where authors were studying giving carboplatin as an immune induction along with immunotherapy, which is atezolizumab. And the design of the trial is a phase 2 Simon staged design. Now, the rationale for combining carboplatin in luminal breast cancer was that some of the luminal breast cancers have actually increased expression of immune-related genes, and it has been shown that in cancers where there is increased expression of immune-related genes, platinum does increase sensitivity of immunotherapy, and that was confirmed in the mouse model. So therefore, this is the first in human study in this situation. So the statistical analysis was, the authors actually planned that you needed at least 3 patients which to be progression free at about 6 months when they would be getting single agent carboplatin with atezolizumab. And they were all invasive lobular cancers. Now, if you see the kind of patients who they had to screen about 37 patients to enroll 23 patients. And the reason why there were some dropouts were because these patients had advanced disease, they had other comorbidities, or they had rapid clinical progression, or they were unfit for the study. Now, if you see the kind of patients who went into the trial was as expected. Of note is that there were about 5 patients who were ER negative or actually were triple negative. So 22% of these patients were luminal triple negatives, and about 80% of these patients were ER positive. Now, half of them were pre-treated with chemotherapy, 1 to 2 lines, and there were other half which were treatment naive. And again, half of them were, most of them were actually pre-treated patients in the adjuvant, who had received adjuvant chemotherapy. Now, if you see the results, now this being a single arm study, what we are looking at is a 24 weeks PFS. That is what is shown by the dotted line. And if you see, there were 4 patients who crossed 24 weeks PFS. And of note, interestingly, of those 4 patients, if you see the green lines is actually triple negatives. So the luminal triple negatives, there were 3 out of 5 in the study who actually crossed 24 weeks, and therefore this study met its primary endpoint of at least 3 patients causing 24 weeks, and therefore it's labeled as a positive study. But my take on it is that if you have a triple negative group where carboplatin itself is an active drug, whether how much of this benefit is actually due to atezolizumab and how much of it is due to carboplatin is something which is unclear in this small sample size. And and the interesting thing to note here was, if you look at the first responses, most of the first responses were seen in about 8 weeks time, in patients who were going to benefit, and they were all partial responses. So in conclusion, the objective response rate of 19%, the clinical benefit rate of 30% makes this study a positive study according to the author's conclusion. But in my mind, this is just a hypothesis generating data, and this needs confirmation in larger trials, especially in ER positive lobular cancers, which comprises the majority. And whether immunotherapy has any role in ER positive breast cancers, it is unclear. So with that, I'll conclude. Thank you for your attention.